So the next speaker is yet again a neurologist. Early in my career, 30 or so years ago, I never would have imagined that we would get neurologists interested in conditions like fibromyalgia. They more than any other field thought that it was sort of the F word. So I'm just really, Lindsey De Lott is a neurologist and a neuro-ophthalmologist. She actually, about a year or two ago, got a CATS R01 grant. It's a new kind of R01 grant where people make a sort of hard right or a hard left turn after their career development award. So her NIHK award was on really in fundamentally different types of research, health services research, big data. But we've been fortunate to be working with Lindsey the last couple years as, again, with her right or left turn, whichever it was. She's moving to study the group of people she sees clinically, the individuals with dry eye disease or with ocular surface paint. So.
All right. And I have the honor of being the only thing standing between everyone in this room and lunch. But hopefully this will be a fun talk and kind of pull together some concepts and things that we've talked about today. And we'll see if I can convince you guys whether or not maybe dry eye syndrome is itself an emerging COPC. All right, so I just have a few disclosures related to this talk. I'm really grateful to NIH for supporting some of the work that I'll get you at the very, very tail end. I have some other disclosures that are not relevant. So first is just to get us all on the same page, what we mean when we say the words dry eye. What is dry eye? And so dry eye kind of comes in two flavors from a pathophysiologic standpoint. There's evaporative dry eye, which just means that the tears are evaporating off of the surface of the eye too quickly, and that's what's causing a number of symptoms. And so this can be because actually tears are really complex. They're not just the watery portion that we all think of, but they're also composed of oils and mucus, which help to keep it adherent to the surface of the eye. Then we have aqueous deficient dry eye, which just means that the lacrimal gland itself is not producing enough tears. And so this is often associated with autoimmune conditions like lupus, Sjogren's disease, where the lacrimal gland becomes inflamed, you get decreased production of the aqueous portion of the tears. But at the end of the day, it all kind of ends up in the same place, which is that whether or not you have evaporative dry eye or aqueous deficient dry eye, there's sort of a series of changes that takes place on the ocular surface. The tears become more concentrated. You end up with inflammation of the ocular surface as a result, and often that epithelium, that kind of clear coating on the surface of the cornea starts to break down. Those cells become injured. And ultimately, folks end up with a number of symptoms. And these symptoms are often described by our patients as irritation, stinging, burning, stabbing kind of pain. There's light sensitivity that is often a component of this. The eyes feel gritty, they feel sandy, they feel swollen. And I'm gonna make a guess that just about everybody in this room has had symptoms like that at some point. Dry eye is very common, we'll get to in just a moment. But for some of these folks, these symptoms are quite persistent. And sorry for those of you that are squeamish about eyeballs. A few lovely pictures. So when these folks come into our clinics and they have these symptoms, we can look for the signs of evaporative dry eye or aqueous deficient dry eye. We do that by putting things like fluorescein on the surface of the eye, which helps us to look at the tear film. And that first picture there on the left-hand side of the screen is showing a tear film breaking up too quickly. It should be this nice kind of greenish yellow homogeneous film over the surface of the eye, but you can see the cornea starting to peek through. The eye starts to look irritated or angry. You'll get actually swelling of that white part of the eye. You can see that the cornea doesn't look clear. It looks rough and bumpy. And if we put that fluorescein on the surface of the eye, we would see that those are actually patches of dryness that take up some of that staining. We call that corneal staining or conjunctival staining. And then we can do terrible things where we put little strips of paper in the eyelid we do anesthetize the eye first, but we can actually measure the amount of tear production, and we have some normative data on what we consider to be sort of normative tear production. We measure this over about 5 minutes. So there's a number of other signs as well, but these are kind of the most common things that we're looking for when folks come in with these dry eye symptoms. So like I said, dry eye is really common. Just about everybody probably in here has had symptoms of dry eye at some point. The best data comes from a recent meta-analysis from 2022 that demonstrated about 8 to 20% of folks have dry eye at any given point in time. But if you look at the errors around, if you look at the 95% confidence intervals around those estimates, it's really wide, 5 to 50% essentially. And this is just in the US only. Across the globe, those data hold. Most people quote somewhere between 5 to 50% of people at any given time have dry eye. And it affects women more than it affects men, about 2 times more often than men. It's really costly. So in some work that we have under review, we've looked at how much, for example, just the drugs alone to treat this condition costs in 2023 to Medicare beneficiaries alone. It was $1.8 billion in just drug costs attributable to drugs prescribed by ophthalmologists and optometrists for dry eye indication. And to put that into context, only about 4% of the claims for these medications were for dry eye drugs, but it was about 40% of the total costs attributable to ophthalmologists and optometrists caring for Medicare beneficiaries. Some older data, if we look at back from 2011, just healthcare costs alone reach about $4 billion, and then the societal costs in absenteeism, missed work, things like that, are probably well over $55 billion at this point in time. But the pain is really significant. It moves beyond just sort of the costs to the system and the costs of the medications. It's really significant to individuals. So about 7% of people have symptoms of dry eye often or all of the time. And in utility studies, again, these are kind of some older studies, but in utility studies, that pain is equivalent to pain like severe migraine, which we heard about earlier, or moderate angina, or pain and also the burden of things like hospital dialysis. And it also really impacts our patient functioning. So if we look at impact scores on different types of things like general activity, walking ability, relations with other people, that impact on those parameters of functioning get worse or interference actually gets worse as dry eye symptoms and severity of pain escalates. All right, so I've just given you what sounds like really kind of the pathobiology of dry eye. So why am I up here, though, talking about this as potentially an emerging overlapping pain condition? And so there's a number of kind of clues as you start to kind of look through the literature, and for those of us that treat patients with dry eye. So the first clue is that there are a number of these patients, a lot of these individuals that have pain out of proportion to the ocular surface pathology. And so just one study, just to give you a sense of this, this is from the DREAM study, which is the largest trial of dry eye, probably the most rigorous trial, published a couple years ago in the New England Journal. And about 20% of the patients that were enrolled in that trial actually had what we call discordant dry eye. They had symptoms out of proportion to the signs that we could see on examination. And this should not be a huge surprise. If we look at a systematic review back from 2015 of 175 different studies from dry eye, the correlations between signs and symptoms are low to moderate at best. So clue number 2 is that a lot of the treatments that we are using to treat dry eye at this point are really just targeting the ocular surface, those processes I was talking about. So the epithelium, the inflammation, things like that on the surface of the eye. And often these treatments don't actually relieve pain for our patients. So again, if we look at Cochrane Review meta-analyses of a number of trials for the common treatments for dry eye, these include things like artificial tears, autologous serum tears, topical corticosteroids, topical cyclosporin, punctal occlusion, where we stick little sort of plugs into the tear ducts to improve the amount of tears on the surface of the eye. When we look at the outcome on pain scores for these individuals, the impact on pain is low to absent at best. In real-world studies that have tried to look at this by folks like Nociplastic, one of my dear collaborators now at Miami, they've really found that pain responses vary quite widely for these treatments. Maybe 30 to 50% of folks have some degree of some response in their pain. Okay, so what's actually really interesting about the eye and what makes it such a great model for potentially studying chronic pain is the fact that we can actually anesthetize the eye, as I alluded to earlier. So again, if you've had an eye exam recently, it's quite likely that you've had this done to you in clinic. So we just use a drop of proparacaine. Within 15 seconds, we can anesthetize the surface of the eye. It is gone within about 10 minutes. And so you can block, essentially, what we would think of as any kind of nociceptive or even peripheral kind of neuropathic pain arising from the surface of the eye. And so we call this the proparacaine challenge. A lot of clinicians will use this in clinic. And this is just one of many studies, but in an interesting study of about 224 veterans, again, almost entirely men. There's going to be a number of veteran studies here because that's where a lot of this work has been done by Nociplastic at Miami, with a veteran population. But what she found was that about 20% of patients had persistent pain after installation of proparacaine, suggesting that the pain is not coming just from the ocular surface alone. And those with persistent pain versus those without persistent pain had higher pre-proparacaine intensity scores. They had higher discordance scores. So again, more symptoms than signs. And then things like light sensitivity, wind sensitivity, some environmental triggers predicted persistent pain in this population. All right, clue number 3, dry eye actually occurs pretty commonly in individuals with COPCs. So this is just one study that is, again, another systematic review and meta-analysis, and essentially shows that number of COPCs like migraine, fibromyalgia, IBS, and what they call like a mixed chronic pain condition at that point in time. That dry eye was actually quite common in these chronic pain groups. And one of the underlying mechanisms in this case is probably some shared genetic factors. So this was a UK twin study that essentially demonstrated that dry eye co-aggregates with other chronic pain conditions, in this case things like migraine, chronic widespread pain, IBS, pelvic pain. And in that co-aggregation was actually stronger in monozygotic twins than in dizygotic twins. All right, clue number 4. So there seems to be an increased prevalence of non-pain CNS-mediated symptoms in patients with dry eye. All right, so I'm just going to show you some sleep disturbance studies and mood disorder studies. There actually hasn't been a ton of work in this space outside of these two kind of groups of symptoms. So there was a large population-based study, about 71,000 folks in the Netherlands, and about 45% of patients with dry eye reported poor sleep quality, and compared to 25% of controls. But if you look again at this, there's a veteran study of 187 veterans, and they showed essentially similar things. High pain intensity was significantly correlated with insomnia in comparison to low pain intensity group and control groups, and there was no correlations between insomnia and the number of signs that you could find on the dry eye exam. Similar things are seen in mood disorders. We know in meta-analyses that depression, anxiety occur at increased prevalence in dry eye patients, and again in veterans, more severe pain is significantly associated with things like PTSD and depression, whereas the amount of signs is not necessarily. So there have been some QST studies looking at hypersensitivity in patients with dry eye. And so I'll just show you a little bit of those data, but it does look like there's some remote hypersensitivity in subgroups of patients with dry eye and some features of central sensitization. So this is a study of about 1,600 women in the UK who had dry eye symptoms, and they were measuring pain thresholds and super thresholds on the forearm, and essentially those with more dry eye symptoms had lower pain thresholds and lower pain tolerance in comparison to patients with less dry eye symptoms. And so again, this is an area on the forearm. Obviously, it's not near the eye, so an area that's remote from the eye itself. And this type of hypersensitivity seems to occur more so in patients who have what we call discordant dry eye, so more symptoms than signs. They also had more after sensations. These discordant patients also had more things like depression, anxiety, PTSD, and non-ocular pain, and so pain in other places. There have been very few structural and functional MRI studies, but there are some changes that we see in these studies that are interesting. So this is a study of about 25 women with dry eye compared to controls, and there's increased gray matter volume in areas important for pain processing, things like the insula. And another study where they looked at increased activity in patients with the chronic ocular surface pain symptoms and photophobia, and compared it to controls. There's increased activation in areas like the insula, the meningeal, the somatosensory network, and the visual cortices, and suggesting that essentially there is perhaps some degree of enmeshment in some of these patients. So there's some, again, this is a pretty new area where people are really starting to think about dry eye a bit differently as perhaps part of a more widespread pain condition for some of our patients. And so there's some important limitations to the data currently. First, a lot of the data just aren't representative of the patients who have dry eye. A lot of the best data have been conducted in veterans. We know that women are more impacted by dry eye symptoms. We don't have a lot of great longitudinal data in these populations. Nobody has really used things like the COPC screener in dry eye populations. We don't have a great sense of sort of the prevalence of all of the currently defined 10 COPCs. It also makes it hard for us to compare to other chronic pain conditions, because a lot of the patient-reported outcome measures that are used in dry eye studies are really kind of bespoke to dry eye, and they haven't really adopted the use of other chronic pain measures and CNS-mediated symptom measures. Aside, from things like mood disorders and depression, there haven't been a lot of studies looking at somatic hypersensitivity or other sort of sensory modalities in patients with dry eye. Our QST and fMRI studies are pretty small so far, and there's just a lot of heterogeneity in the cohorts. The way that folks get included into these studies can be for any variety of dry eye symptoms, dry eye signs, maybe a diagnosis of dry eye rendered by an eye doctor themselves. So we don't have a lot of consistency between those studies. So some of the work that I feel very lucky to be doing and I'm excited about is happening right here at Michigan. So I have a current R01 sort of trying to address some of these issues with some of the data that we have about patients with dry eye and trying to define the subgroup of patients that we think might have nociplastic pain as the primary pain mechanism or a maintaining pain mechanism for their ongoing and chronic ocular surface pain. So we're doing some clinical phenotyping, neurobiological phenotyping with multimodal QST and fMRI. We're also using corneal confocal microscopy because we can anesthetize the eye. We can use a contact microscope and get some really interesting images of things like the structural imaging of the cornea itself as well and the nerves in the cornea. And then looking at which of these sort of clinical and neurobiological predictors might predict things like response to a topical anesthetic like proparacaine and trying to validate those findings. And so I'm so grateful to all the folks at the Chronic Pain and Fatigue Research Center for basically guiding me through this process when I sort of took the turn into pain. I have a wonderful mentorship group. And so I will leave it at that. And so I guess leaves you guys with the question of, is this an emerging COPC?
Time for a question or two for Lindsey. Burrow? Okay, you each get one. Okay, you're it. Okay, who's going to go first?
Fantastic stuff here. Thank you for making me think about something that I hadn't really considered. To your knowledge, is there any sort of understanding or information related to whether or not there's like seasonal and or geographic variation? You mentioned a little bit of like environmental contributors, perhaps with like wind and light. So I'm thinking like the closer you live to the equator versus the pole, anything that actually experiences 4 seasons when there may be more or less wind or light, it's very interesting.
Yeah, so I mean, there's definitely differences across the globe in certain countries, which gets to that a little bit. So there's probably there's definitely some environmental triggers. I don't know anything about, there's nothing that I know of like specific latitude, longitudes in which dry eye groups kind of cluster. But there are definitely environmental triggers for folks.
Mine is very simple, very nice talk, very exciting. Visual QST.
Yeah.
Have you?
Yeah, so it's actually part of our protocol. And so we are looking at using the same protocol that was used in those post-op pain studies, and looking at both brightness and unpleasantness of sort of a repetitive kind of visual pattern.
Do you have any inclination of whether, again, thinking from COPC or just clinical intuition, how that is going to go?
Yeah, I think it's going to be, it might be a bit tricky. I don't know how much we're going to be able to tease apart. I think the brightness piece, and I think the brightness and the unpleasantness are going to be super interesting because my guess would be that, my hypothesis would be that the brightness actually doesn't help us necessarily to distinguish between those who clearly have more of a nociplastic kind of phenotype versus those who have dry eye that is all being really mediated by changes on the surface of the eye. And the reason why I say that is because as light sort of passes into the eye, when the surface of the eye is truly dry and we have breakdown of the epithelium, it scatters light across the retina, and that can actually enhance the sensation, that sort of brightness sensation, that unpleasantness. So I think that what's really interesting with the sort of current visual testing paradigm using this kind of alternating checkerboard, this repetitive kind of pattern, is I wonder if that will actually be more distinguishing, in particular in this patient cohort. And I think it's going to be some really fascinating data.
Great, thanks so much. It's time for lunch. We'll reconvene in about 45 minutes. So lunch is in the same place as all the other food. So.